please go ahead.
Respected chairpersons, it's a great honor to be here, to be speaking 7 times about the role of CT, how it helps in pre-procedural planning and evaluation of a CTO. Now, all of us know in this audience, we will not be, all of us are convinced about the importance and benefits the CTO angioplasty has as far as the quality of life and the long-term outcomes are concerned. The most important thing as by far for a CTO recanalization is the ability and the experience of the operator as far as the success rates are concerned. But it's also important to know that if you have a good knowledge of the coronary anatomy beyond the occlusion, it also helps in planning a procedure and also achieving a good degree of success. Now, as you know, if you're doing a procedure second time, the chances of adverse events, MACE, is considerably higher than if you're doing a procedure for the first time. And how does CT help in CTO recanalization? It helps you in pre-procedural planning. It predicts the procedural success, and you guide by crossing in as low as 30 minutes. It improves procedural success by real-time integration of 3D CT data onto the fluoroscopic image. And it's a one-stop shop for anatomy, perfusion, and viability. Now, for the pre-procedural planning, this is an example of a young man who had a historical MI, anterior wall MI, 6 months ago. An angiogram shows a totally occluded LAD, but there's no stump. We did a CT to know what the extent of occlusion is, what the distal vessel looks like, and here is what we got. Sorry. Here, this is a pointer here. This is the totally occluded vessel. We can see there's a speck of calcium here, but as most of the vessel is seen as a phantom image, we can gauge the extent, the size of the vessel, as well as the length of the occlusion based on this. Now, these are examples of very good CTOs which a beginner can venture to try, because there are short segment occlusions with hardly any calcification, and this would be very easy for a beginner. Now, these are examples of tough CTOs in the sense there are multiple occlusions distally, dense calcification. As you know, the most important predictor of a CTO success would be the extent of calcification. And the CT is a very good investigation for looking at calcium. You look at the corner, you can see there's a circumferential calcification, and this cannot be picked up very well on a conventional angiogram. What about predicting the predictors of failure? If you have previously failed attempt of CTO revascularization, the chance of success is less. Increasing age of occlusion, presence of marked calcification, which can be picked up very easily by CT. Long occlusion length. There was a study which showed that 32 millimeter occlusion length was an adverse predictor of success. A blunt proximal stump, excessive vessel tortuosity within the occluded segment, presence of a side branch at the occlusion site, antegrade bridging collaterals, and multiple CTOs. All these things can be picked up very well on a conventional CT angiogram prior to embarking on the procedure. Now, as I mentioned, calcification is the most important predictor of CTO success. So it helps you planning your wire strategies, also the requirement for additional rotablation, and to see if your stent is adequately expanded also. As an example of a patient who had a totally occluded circumflex in the lower corner, and you can see that the conventional angiogram just showed a totally occluded vessel, but a CT did pick up extensive calcification, which needed wire escalation strategies. Though the JCTO score my previous speaker has mentioned, it just tells you the presence or absence of calcification, which is not at all what is required. What is required is the extent of calcification by CT, and this is what is called a CT Rector score. If you have more than 50% circumferential calcification, it means that your chances of success is going to be less. Now, there's a study which compared a JCTO score by CT versus JCTO score by conventional angiogram, and they concluded that JCTO score by CT was by far superior to conventional CT angiogram, conventional angiogram, as far as predicting the outcomes were concerned. This examples show you that because you can pick up extensive calcification by CT, which may not be seen on conventional angiogram. This is another study which showed that JCTO score as well as predicting the procedural success and 30-minute wire crossing, the area under the curve was by far more superior in the conventional CT angiogram versus the conventional angiogram. We went a step further. We have a in-house 3D printing lab in our hospital. We went and did a 3D printing of all the patients who had a prior CT, and we have a specialized technologies available for 3D printing. And what we did was we get a three-dimensional perspective. This is commonly used by pediatric cardiology colleagues for deciphering complex congenital anomalies. So we use that in CT, and this as an example of a patient with a totally occluded LAD. What we see, the conventional angiogram is very little vessel antegradely, and we hardly see a good collateralization with a retrograde RCA injection. So this patient needed what we call a CT angiogram, and we reconstructed a vessel based on the phantom images which we got from the CT angiogram, and we could make out the extent of the occlusion as well as the quality of the vessel beyond the occlusion. So this is a video which just tends to show how we go about doing a CT reconstructing with the 3D printer, and this is how we draw the images, and then we reconstruct the images based on the phantom images, and then do a 3D reconstruction. So this 3D reconstruction not only helps you in telling what the distal anatomy is, also tells you about the length and the quality of the vessel beyond the occlusion. This is another example. This is a patient who had a successful recanalization post intervention. This is a patient who had long segment mid-LAD total occlusion, and by doing a reconstruction, we could make out the length of the occlusion and the distal vessel quality. This is the example how a 3D printing is done in the lab, and this picture here on the right shows how we can reconstruct the 3D printing images and get you a three-dimensional perspective of the occlusion as well as the distal coronary tree. I'm stuck here. Yeah. Now, these are the images of the CT printing after we do this 3D printing. It gives you a three-dimensional perspective of the entire coronary tree as well as the length of the occlusion and the presence and absence of calcification. Last and most important, we use what is called a CT code registration in the lab. We have a Siemens machine which helps you to automatically load your CT images just beside or superimpose on your angiographic images, and then we can outline the vessel based on the phantom images we get on the CT, and we can actually orient a wire based on the orientation of the vessel. Based on the orientation of the vessel, we can actually go ahead and plan your procedure. Now, this is an example of a patient who had a CTO of the PDA, and with using a CT code registration, we could orient our wire into the PDA and achieve a good result. This is an example of a retrograde CTO, whether we could orient the retrograde wire onto the native RCA based on the code registration. So just I want to conclude by saying that CT is very important, not only in identification of CTO, it also helps you in predicting the clinical benefit of revascularization. It helps you in planning the procedure. It helps you the procedural outcomes of the CTO PCI. It also helps you in visualization of the procedure by using CT code registration in the lab. Also tells you the long-term follow-up and the presence of the patency of stent. So just conclude that pre-procedural CTA helps in procedural success and improves outcomes of CTO. 3D printing provides a three-dimensional perspective of the totally occluded vessel, and CT code registration improves procedural outcomes. Thank you very much.
Thank you. Thank you very much for a very much excellent presentation.
Dr. Emani,
yep.
How often you use CT before a complex CTO PCI in Japan?
In Japan, it depends on the institution you may ask, but generally speaking, in Japan,